Good morning and welcome, everyone. I'm Beth Lown, Chief Medical Officer of the Schwartz Center for Compassionate Healthcare, and I am just delighted to welcome all of you to the Schwartz Center's 2022 Compassion in Action Healthcare Conference. The Schwartz Center, as many of you know, is a Boston-based nonprofit organization with international programs dedicated to sustaining compassion in healthcare and supporting the healthcare workforce through our programs, education, and advocacy. The world has certainly changed since we began these conferences 5 years ago. We are still in the grips of the pandemic, although we now have more tools to manage it. But burnout remains rampant among healthcare practitioners, and the equities and the violence that breed moral and traumatic stress are sadly long-standing and, if anything, increasing. These are really very challenging times. And that's why the purpose of this conference is to offer a bit of respite within the warmth of a caring community and some practical solutions. The theme of the conference this year is Healing Healthcare, Revitalizing and Reshaping Our Future. And so you will hear from national thought leaders, innovators, clinicians, and your peers, all of whom share a commitment to compassionate care and have grappled with how to sustain this care in today's turbulent environment. One of the gifts that I have working with the Schwartz Center is that I have the honor of hearing the stories of caregivers and leaders every day. And I'd like to share a story that I heard recently from a nursing home medical director about her experiences when she faced her nursing home's first COVID-19 outbreak early in the pandemic. In a word, she was terrified. There were no vaccines, no evidence-based treatments, very little PPE, but she made it her practice to go from nursing station to nursing station to speak with the staff on every shift, all shifts, weekdays, weeknights, weekends, to address their concerns. And the staff met frequently, of course, for town halls where the recorded information was then able to be shared very widely, not just with employees, but also with the residents and their family members. And she was just so completely humble and honest. I mean, she got really used to saying, great question. I don't know the answer, but I'm going to do my best to try to find out and let you know. When they were finally able to vaccinate everyone, she was absolutely thrilled, very excited, but she knew she was going to have to address vaccine hesitancy, particularly among the staff. So again, she went and she talked to everybody, the CNAs, the nurses, people in the admissions office, housekeeping, dietary, therapy, leaders, everyone really, just to give them a chance to ask questions and to really have a personalized conversation. And she was especially concerned about the staff on the COVID unit. So she went in to speak with the CNAs there on the night shift, and she sat with them really far into the night. And they had these really open and honest conversations. And just as she had been honest with them about what she did and didn't know, they were very honest with her. They spoke really openly about their apprehension and about their mistrust, given the long legacy of mistreatment of people and communities who are Black, Indigenous, people of color by the healthcare system. And ultimately, what she said was that everyone who had participated in that conversation on the unit that night got vaccinated. She said it was perhaps the most meaningful experience of her career. And I'm sure she was not just talking about the outcomes, that everybody got vaccinated. She was really talking about what it meant and felt like to her to really be present and to engage in those difficult, open, and honest conversations. So what can we learn? What can we learn from that story? That personal connection and support are absolutely essential to our health, to our well-being in so many ways. That leaders who prioritize worker well-being show this, not just with fancy words, but by showing up, by being honest, by working really hard to build or rebuild trust. They create those kinds of compassionate organizational cultures, and they actually allocate budget and resources to ensure protection from unsafe conditions, whether that be from infectious diseases or exposure to violence or traumatic stress, bias, and discrimination in the workplace. We are not starting from square zero. There are effective solutions and promising practices in healthcare to reach this goal of compassion, sustained compassion, and compassionate organizational cultures and resources allocated appropriately. You're going to hear about some of these during the conference. And I encourage everyone to read the Surgeon General's recent advisory on building a thriving healthcare workforce. Also, the National Academy of Medicine has an action collaborative on improving clinician well-being and resilience, and they are working on the final draft of their plan, which they will issue shortly. We've just put the links to those websites into the chat if you'd like to copy them for later. I also want to tell you about the Schwartz Center's Healing Healthcare Initiative. This initiative is a relational leadership program. It's aimed at strengthening the compassion, collaboration, and effectiveness of organizational leadership teams as they implement concrete actions and activities to support the workforce. The key principles of HHI, as we call it, are shown in the slide. And this comprises a framework that really grounds cultures of compassion and well-being and enables them to flourish. Our Healing Healthcare Initiative will provide support, community, programmatic resources, and a roadmap for Schwartz Center members to implement the recommendations in the 2 reports I mentioned and others. And participating organizational leadership teams will meet with us with strategy mentors and with guest experts. They'll have the opportunity also to gather together in learning collaboratives so that they can actually learn and share experiences with other leadership teams from around the country. We invite your organizational leaders to consider applying to participate in the pilot of this program. Applications will be opening in September. We know that compassionate healthcare organizations distinguish themselves. They stand out because they value, protect, and prioritize their workers' health, safety, and well-being so that they can continue to care for others. Because when compassion thrives, people, teams, organizations, and systems also thrive. Today, we're excited to host 2 days of important and inspiring content, and I'd like to thank our speakers, the conference committee, and other partners for making this conference possible. We're grateful to our national business members and our supportive partners for their tremendous support. And we're grateful to all of you for joining our 5th annual Compassion Action Healthcare Conference. Thank you so very, very much for being part of the Schwartz Center community. And now I'm very pleased to welcome our opening keynote speaker, Dr. Thomas Fisher. Good morning, Dr. Fisher. So Dr. Fisher is a board-certified emergency medicine physician at the University of Chicago. He's serving the same Southside community where he was raised. And he does a lot of things. In addition to his day job as a physician in the emergency department, he has been and is a consultant. He's previously worked as a senior executive for Medicare managed care health plans. He's headed up health delivery transformation efforts. He was a White House fellow during the Obama administration. He's worked on the development of a Health and Human Services Action Plan for reducing racial and ethnic health disparities, among other things, when he's not writing books and running and jogging. So I really greatly enjoyed his newly published book, The Emergency, A Year of Healing and Heartbreak in a Chicago ER. And I've really been looking forward to this conversation. So welcome, Tom.
Beth, thanks so much for having me. It is just incredible work that you all are doing, and having this opportunity to discuss how we take care of each other as caregivers is just not often done, and one of the most critical components of the health delivery process. I mean, we're people too, and you can't take care of people if you're not whole yourself. And so thanks for inviting me. This is an exciting day.
Yeah, thank you so much. And thank you for saying that. So you grew up on the South Side of Chicago, son of a public school social worker and a physician. Do you feel like sharing a little bit about how your family and family life perhaps played into your interests that developed a little bit later on in health policy, and especially on the influence of social and economic factors in healthcare?
Yeah, I mean, and I write a little bit about this in the book, but what exists on the South Side of Chicago is very unique and special. It is in the middle of the third most segregated city in the country, is a vast community of Black folks and an archipelago of unique neighborhoods, some middle class, some upper middle class, some poor, that interrelate and interdigitate. And my parents moved to Chicago independently. Neither one of them were from here. They both came from other Midwestern cities and came to develop a life. And they chose that community because of its opportunity to see the full breadth of humanity and to exist in a very specific way that allows for me to have a Black pediatrician and a Black dentist and a Black orthodontist, and and the fishmonger was Black. And that's kind of a very unique experience in this country, that was born both from protection. So many of the Black folks on the South Side fled the white terror in the South and migrated north during the 40s, during the Great Train Migration, and then found community amongst one another and served each other by taking on all of the components of a society that aren't given to you. They found shelter. My parents found shelter in that community as well. And then my mother's work as a social worker, where she saw children facing some of the most complex challenges, either in their own household or because of tragedy and loss, pushed her to remind us how important it was to be deeply embedded in the community, to serve, to be thankful for the privileges and advantages that we have, and also to continue to return that to the community. And I think that there are a lot of ways to be Black in America that are all normal and valid and positive. And I experienced one of those ways, one of those that's, here on the South Side of Chicago. And I wanted to both breathe life into the complexity of that community that birthed everyone from Harold Washington and Mahalia Jackson and Lorraine Hansberry and Emmett Till and Barack Obama, and recognize that serving that community and taking care of folks who exist within that context is a specific one. It's not just simply a two-dimensional, all Black folks are the same. There's a community here that I wanted to reveal, and one that gave me a sense of purpose and a sense of belonging.
Yeah, for sure. I mean, you really get that sense reading the stories that you share, the stories of the patients, and the way you think through these letters that you formulate and then write to these patients, explaining your understanding of how this came to be. We'll get into that in a minute, but I really appreciate that. And I can feel your sense of commitment, the need to serve and the need to give back. And certainly that is deep rooted, and it's a sustaining sense of purpose. We're hopeful that could be sustained for more of the healthcare workers who are out there trying to serve. So this book, Emergency, it begins in February 2020, just as the first wave of COVID, in case you're interested, folks out there, is hitting the United States. It's engulfing your community. The community you grew up in, the community surrounding University of Chicago. So, when you think back on that, what made you write the book at this time? What happened that drove that decision? And, what were your hopes for the book?
I had actually started writing the book before COVID descended. I'd spent a lifetime taking care of people who were trapped. When I say a lifetime, I mean a 20-year professional career taking care of folks on the South Side. And what I realized is that they were sitting in an unjust system that where the city's segregation led them to be concentrated in areas with few resources, protections, goods, and services that had a toll on their health. While I recognized that relatively early, I mean, I think in medical school, we had conversations about what we call now social determinants of health, but at the time we described how context, where we live, learn, work, and play, influence our bodies. I embarked on a professional career that endeavored to change those things. That began with research, moved to policy, worked on systems, all with the hopes of freeing the patients that come to me in the emergency department from the traps that rob them of their health. And while I had successes and failures, what I learned was that there are patterns within all of this. You know, at the end of the day, we're all going to get sick, right? And when we do, except for the wealthiest among us, we won't be able to afford the care that is given to us that might be life-saving. And so we have a healthcare system that bends towards those who have the best insurance with faster service, higher quality care, and more amenities. And what we've learned over time is that those jobs that offer the best insurance are sorted by race. We've seen the studies that show that if you're a white man without a college education, without a high school degree, you're more likely to get a high-paying job than a Black man with a college degree. When you take that data and combine it with the planned and executed segregation of a city like ours, what you'll find is that Black folks are pinned into communities with high rates of uninsurance and Medicaid. In a community right close to my hospital, Washington Park, you'll find that 12.5% of the population is uninsured compared to 2.5% of the population up in Lincoln Park on the north side, a wealthier, whiter community. And the providers follow those same insurance patterns and concentration of resources with their provision of services. And so if you look at a map of the city segregation and the map of its concentration of providers, they look the same. I wanted to start describing that to the patients that come into the emergency department, that the reason these things are happening to you are because of a broad and complex ordering of society, one that started well before you were born. Then the pandemic descended, which gave me an opportunity to describe how the way our society orders its goods, resources, and protections can influence our bodies and our health in just a matter of weeks. Whether or not you could stay home and work in front of a screen as compared to stocking shelves or working in a meat packing house influenced whether or not you were infected, whether or not you brought that infection home to your family members. And what normally takes 30 or more years for the distribution of protections to influence our health was truncated to a matter of weeks. And so that's why, while I had begun writing, it became the centerpiece. You know, one of the emergencies that I talk about is the pandemic. There are other emergencies. There's the emergencies that happen every day on the south side of Chicago. A waiting room with people waiting 8 hours is an emergency. People falling ill too young, those are emergencies. The pandemic of gun violence that I see in practicing in the busiest trauma center in Illinois, that's another emergency. And so I wanted to thread all of these things through in a way that was meaningful to people who are normally receiving care and not delivering care.
You know, I think, thank you for that. I think one of the most powerful lines I remember reading in your book was going through this explanation of how the situation for this particular patient you had evolved in the first place. But the line that caught my attention was, "This is not your fault."
Mm-hmm.
And I think there's something so powerful in that message. And maybe that's a bridge to, the empowerment that we need to begin to advocate for ourselves and each other. I really appreciated that statement.
I think it's easy to forget, not only for the patients, but for us as providers, that as we attempt to do what we've been trained to do, to heal those who come to us with wounds and illnesses and wounds that we've been trained to fix, when we're unable, we feel as though it's a personal failing. Yes. Without the recognition that we're working within a context, within a system that's working exactly as defined, that gives us too little time and too little resources to give those who need the most the care that they deserve in a reasonable fashion. And so there's a little bit of grace that we need to extend to ourselves as well as we think about this, but also that grace needs to extend to action. We need to be willing to stare and be honest about what it is that we're confronting so that we can change them.
Yeah. So a little bit of self-compassion and also just a gathering together of collective effort to notice. I think, when you live inside a culture, sometimes it really gets hard to see it. It's the lens you're looking through and you can't always notice things anymore, I wondered if you would actually set the stage and maybe read one of an excerpt, from your book. You use this wonderful device of sort of interspersing your own narrative and reflections with these letters that you've written to patients, which I assume you didn't deliver to them, but they're more explanatory than, for the reader than anything else.
Sure. The book alternates chapters. One chapter is taking the reader by the hand and bringing them to the bedside. And in that way, my goal was to reveal the intimacy between strangers that occurs within the emergency department, where people who have fallen ill or are injured come to you for help and share with you secrets that they very rarely revealed to anyone else. And they disrobe in front of you, both literally and figuratively. And in those moments, folks are really human. And I wanted to help to animate that as a component of our understanding of what healthcare is. And then the subsequent chapter in this alternating form will be a letter to somebody that I take care of to help them understand how these broad system influences have shaped their particular experience on this day, whether it is the reason that they waited so long, or or help to understand why they have the illness that they have, right? And so towards the end, my mother got trapped in one of these healthcare system situations, one that is quite familiar to many people, where people wait too long and receive too little. And I wrote her a letter, and I wanted to share just a couple of paragraphs from that that serve as framing. So I got the book. Mom, in 2 decades of caring for people on days they wish never happened and will never forget, I've learned something else. Everything, our ability to create, love, and imagine, is contingent on the health of our bodies. When our bodies inevitably falter, restoring physical abilities falls to my ancient and intimate profession. In those moments when people teeter on that razor's edge of life and death, people often shed their masks of status and ego, revealing that which is most human. On those occasions, some demonstrate a grace and clarity that feels timeless, a connection to something that is in all of us. Then, as doctor and patient, we connect through essential expressions of our humanity, reciprocity, listening, and honesty that sums to a level of trust rarely shared between strangers. And then I touch people right where it hurts, sometimes cutting them in order to help them. Healthcare connects the most intimate parts of both patients and physicians. And this kind of familiarity means coming to terms with the fact that our bodies are the biological platform on which every other part of life stands. every single thing we do, individually and collectively. Our healthy bodies allow us to connect to one another and to the infinite. Caring for our bodies and caring for each other is a necessary precondition of life. In other words, health is a human right, the thing we owe each other. In your time in the ED, nobody loved you enough to resolve your suffering. My colleagues apologized for your experience, and I accepted their apologies. I knew they couldn't do better. Over the path of my career, I too have struggled to honor this sacred pact in a healthcare system that is deeply unjust and dangerous. Despite high-minded mandates to serve everyone, our establishments find ways to reject, defer, deny, and bankrupt many of those who seek care. In the end, the length of our lives and quality of our existence are silently transferred from poor to rich and from Black to white. These strategies are so embedded that this collection of actors would not perform better if their roles were reversed, and all of a sudden the poor and Black had control of these broken systems. I can't protect my patients, and when it mattered most, I couldn't turn an organization towards justice when it was on the line, and I couldn't protect you, Mom.
It's hard to hear, and can only imagine how you were feeling, let alone your mom. What happened? Is she okay?
She's fine. She was misdiagnosed and largely had delayed care that she ultimately sought resolution elsewhere and received it. And I think that there are a couple components of that passage that I think are important. One of them is that these are systems at work. This wasn't the failure of one physician. I mean, in fact, I've failed in the exact same ways. I've taken too long and been unable to do what I wanted or needed to do. Handoffs have been dropped. Diagnoses have been missed. But these are systems that are working exactly as designed. And until we design new systems, we won't have better outcomes. And one component in that passage is that if you were just to simply change the leadership and have the leadership be poor and Black instead, the systems remain structured in the way that they are, and they won't all of a sudden be just simply because we have different leadership. And in fact, I worry sometimes that the magic wand that we wish to wave is simply to say, well, let's just get better leaders in place. This is not going to be solved when we remove villains and insert heroes. We have to reshape the systems themselves and redefine what it means to deliver care and extract this zero-sum equation of winners and losers, where we have accepted constrained resources and deliver the best of our services to those who can pay the most, rather than delivering it to those who need the most. While certainly there will be times where the people who have the most often need the most, people who are very wealthy get critically ill sometimes and should be cared for in the way that they deserve. But it shouldn't be their wallet, their insurance, their capacity to pay that defines whether or not they get prompt, high quality, and compassionate service. And so when my mom was trapped, I wanted her to be treated like a VIP. I wanted her to get that pathway around all of the snares and traps and delays. But at the end of the day, every mom deserves that. That should be exactly how we define the healthcare system, which is why I like to read that passage. And it reminds me of how challenging it is to do what we all ultimately want to do. I don't think any physicians, nurses, respiratory therapists, pharmacists, I don't think anybody wants to be the one that is reallocating services away from those who need the most. And yet many of us find us with that role exactly.
Well, you mentioned a couple of really important things here. I mean, the first is that you really can't effect change just by changing the leadership if the fundamental system and the structure of the system and the processes and the payment and everything else remains the same. That's not an effective solution. And And I think too, we know from the patient safety movement that when things don't go the way we might like, there's always a process that has resulted in that particular outcome. And it's best to take a look at those rather than blaming individuals, let alone criminalizing medical error, which we've unfortunately seen recently. The other thing that you said, though, echoes something I've heard, Don Berwick say, that health and healthcare is a human right. And it is not thought to be so in this country, and I don't know how to solve for that problem. It remains perplexing and really hard, because I do think that if we could just expand healthcare access, our health outcomes and other things would really vastly improve. I mean, a lot of it is just because people cannot access care. I don't know what you think about that.
Paul Farmer's lesson, one that he exemplified in his work and in his life, is that regardless of who you are or where you are, humanity should be centered in the services delivered by the healthcare system, period. That is rarely exemplified on our shores. And I think that there are a lot of reasons for that. I think that on the one hand, the influence of profit allows for rapid expansion of efficient systems. But on the other hand, what it does is extracts wealth and resources from those who have the least and extends them to those who have the most, particularly it becomes even more galling when you realize how we are all contributors to the current healthcare system. I mean, all of the trainees are paid for by Medicare. Many of our healthcare institutions are nonprofit, which means they're supported by taxpayer dollars. These are shared resources that ought to fall under the purview of democratic decision-making that still don't. And so when you have these shared resources, these taxpayer-supported resources that are then having the best of their service funneled to those who pay the most, it's an anti-democratic process, one that is fundamentally unjust. And I'm not sure how we undo that. I do think that there's a component of this that won't ever be solved until we recognize that this simply reflects our larger society. Much of our health is fundamentally a component of where we live, learn, work, and play. The communities around my hospital on the south side of Chicago have been underinvested and over-policed. People run a gauntlet of foods that are toxic and violent streets and few job opportunities. And none of that is random. And so what you'll find in Washington Park is a life expectancy of 59 years compared to the Gold Coast on the north side, where the life expectancy is 90 years for men, a 30-year life expectancy difference. That recognition that we are all a part of this together, that we owe something to one another that allows for us to express our fullest humanity, to dream and love and hope and participate. That's not strictly a healthcare system issue. That's a societal issue. And if we get to those societal challenges and fundamentally decide that we're not going to allow for this racial caste system to dictate our access to the good services and protections and dismantle many of the structures that have supported that over the years, at that point, we'll have so many more options in our healthcare system, because we will have had a society that reflects a more just understanding of who we are as people. Things that we've seen codified in language, but we don't express them in our actual society.
You mentioned a couple of things, Tom. You do bring up sort of the issue of community engagement and participation and change, and I wonder how you think about that and how you think about really getting that going. I mean, how do communities, and just, I guess the question really, Well, there are two questions. One is, and I'm seeing it coming up in the chat. One is, what can we as just individuals do, to address this? Because it weighs heavily, if you feel it and you see it, now your eyes are, even more open, perhaps, especially in the pandemic. What can individuals do? But I wonder if first we can just sort of see something about how can you engage communities to help advocate, push, participate in creating the change they want to see?
Yeah, I mean, this is really challenging because I think the first step is to recognize that this is intergenerational struggle. I think early on in my career, I felt that this was just a grand misunderstanding. And as soon as better solutions end up on the table, they will be implemented and we'll start to see rapid progress towards improving the health and healthcare of folks who need it the most. And what I quickly realized is that there are as many people pushing in the opposite direction as there are trying to improve things. People who don't see themselves as part of the problem, who are simply following through on what they've been taught are the best allocation of our goods and resources, and who understand that profit is important and have a culture of one that is very consistent with the mainstream of our country that says, look, there are going to be winners and losers, right? Now I realize that this is not going to happen anytime soon. The sorts of changes that are required are large and require persistence and sustained attention. I think what all of us can do is be honest about it and never turn away, even when we can't do anything about it. I think we have a bias towards optimism and that things are actually just fine, and we're making progress. And I think that when those things are the case, we should say so. And when they're not, we should not shy away from the recognition that things are the same as they were. I mean, the number of Black male doctors now and in 1940 is about the same. Our health outcomes are declining. We've seen years of life expectancy shaved off all folks, but Black folks in particular, and in Chicago, Latinos as well. We know that wherever we've looked for health inequities, we've found them. And we know that that's not while there are implicit biases that drive some of this, most of this is because we have a system that needs to be addressed. And I think we should just consistently and persistently be honest about that, even if we can't fix it today. I think the other part of that is you can keep your own side of the block clean. You can take inventory about, particularly for those of us who are providers or healthcare leaders, are we making neutral financially decisions that are driven financially that seem neutral, but actually make inequity worse? When we create VIP floors, are we taking resources from the collective and giving them to people who have the most resources? When we participate in these executive and VIP end rounds, when we hire based on what we've always done as opposed to what we ought to do, are we cultivating a diverse population? Are we engaging in system change? Or are we scapegoating, looking for heroes and villains? I think we can keep our own house clean. I also think we can build new things. I think that while we have large structures that are extremely influential, our medical centers, our government, some of those are going to be very slow to change. And for some people, that means their best path is going to be to build something new, to patch in some of the cracks that our patients are falling through with new solutions that can only be built from the ground up while we wait for our institutions to come around. I think one of the upsides of our institutions is because they're so large and influential that if they change just a little, they have massive impact. But the capacity to even change a little is very difficult and requires a lot of variables internally and externally to align in order to push them forward. Can't always wait for that. Sometimes you can just build something new and proceed in that way.
Yeah, and actually, it's people who are on the front lines of care, so to speak, who know best, I think, who they're there to come up with potential solutions. I heard a conversation that involved it, and in fact, we're going to have later in the conference a conversation between Rashika Fernandopouli and Kedar Marte. Kedar's from IHI, and he cites an example, Kedar does, about a group at a particular system gathering data, realizing that they had significant disparities, for example, in stroke care, the time where a patient is identified, with a particular diagnosis and then waits to get clot busting medication, and that Black patients were, not getting the medication in a timely fashion, or as timely as white patients were. And they use performance improvement, just improvement science, to try to fix that, and wound up, I guess, creating algorithms and order sets and things like that, and found that within a relatively short period of time, they were actually able to better equalize the distribution of the outcomes they were looking for, which is equal time to medication.
Mm-hmm.
So that's something that I think a lot of people in healthcare, might be familiar with, that kind of approach. And certainly everybody has quality departments within their healthcare organizations if they want to participate in stuff like that. But I mean, that's just one tiny, it's not so tiny, but it's an important example. But just to give the sense that there are things that we can do, and we do have ways of thinking about it, and potential solutions. It may not solve the whole entire thing, but if you try to exert influence over a sphere, you might have some influence over and gather like-minded colleagues and coworkers to address a problem that you've identified. There's a lot of power in that, and it's kind of energizing and activating, if you're able to accomplish the outcomes that you want to see.
I love that example. And I've got incredible respect for both Kedar and Rashika, two people who I consider friends. And I think that part of what they exemplify in that example is the value of data and being honest about what you're saying, which requires that you collect it and use it in order to solve things. And I think that's part of just like keeping your house clean. Can you, in your own place, solve these problems that you see in front of you? And I think that framing health inequities as a quality issue, I think, is important. I also think that within large institutions, what makes them work is, they're very good at moving large things forward, but that requires incentives. Are you paying for that? Are you penalizing for that if you're not creating equitable care? And I think that if we are tying our success and our measures of quality to not just, the three-legged stool of cost, quality, and access, but also that none of that counts if you're also inequitable, that helps to add progress. I think so much of our healthcare system has these, crosswise incentive structures. The bread and butter of emergency departments is throughput.
Yeah.
Right? The bread and butter of hospital systems in general is heads and beds.
Yes.
Like those things are in conflict, and neither one of them prioritize patients. And so the better we can resolve some of those incentive conflicts and instead incentivize what's right for people and what's right for equity, the further along we'll get. I just find that those are very hard conversations to have if we aren't also telling the truth about the importance of our shared humanity, the data around inequity, and the fact that it is our systems that are designed to create them.
Yeah, I think that's such an important point, Tom. I mean, I think if anything, that people take home from what you've written, that really has to be it, Anyway, we have some questions here that are coming up. One is Oh, there's some great questions too, actually. One is, I agree we are complicit in the state of healthcare. How do you address the lack of value placed on true health in this country? Where do we start? That really is exactly what you were just talking about. And, I don't know if you want to talk a little bit more about value-based care, value-based payment, or go take that in another direction.
Can you repeat that? Were they referring to?
They were asking about how do we address the lack of value placed on true health? So it gets to, are we creating health, or are we just patching up sick people and as you say, incentivizing volume over value?
Yeah, I mean, so much of this is the way we have structured our payments, and some of that is, look, we pay more for the more we do in general, and I think there's been a multi-decade long progress towards transitioning that towards outcomes and other value-based metrics. But I think all of that requires it being centered in an understanding of, what is it that matters here, right? And I think that for too long and for too many, we have this elevation of profit over people. And with the recognition, with the tacit or implicit understanding that if we get the profit equation right, by definition, we'll get the people part right. And I think that that's not true. And I think that instead, we need to really see that these systems are in the service of humanity, that the goal here is to make people better. And I don't think that that is a short order of transformation. I think that's something that takes a long time for us to inculcate broadly, because I don't think that's natural for our society to have had that sort of understanding that humanity is at the center of what we do. Right? While that ought to be the case in healthcare, shouldn't that also be the case in education? I mean, we're taking care of children here. So much of that should also probably be the case in our food supply and our public health initiatives. And that we're not really having that conversation except in small pockets. And when we do see that regularly, we deify these folks as heroic, when in fact, maybe we should all have some component of that in our work.
Yeah. Well, you're raising a really important point too. I mean, we can try to incentivize value instead of volume, but that still doesn't necessarily create health, because you're paying for services related to illness and disease rather than trying to address the root causes of those issues and problems. And so you brought up, food and some of the other kinds of what we call the social determinants of health. And I think this is such a complex question, and it's not going to be solved with one simple answer, but somehow marshaling all these possible approaches together through some, central coordination would be just incredible if we could ever get there.
I mean, the more leaders we have in place that see this as their charge, the better off we'll be. I wonder how well our leadership training writ large centers humanity in its understanding of what leadership means. Often it's about communication and consensus building and fiscal responsibility and things of that nature, but all of those, without having the central pillar being one related to humanity and healthcare, I think can easily lead us astray. There's also this sort of, what are the nuts and bolts tactics that one can use to create a system that both works and also incorporates values within them? And I think that is worthy of long conversation, because there are implicit values that we're already infusing into these systems that we can be more intentional about as we make decisions and when there are conflict. I would say, like, most of the time, these questions don't much matter. I think most of the time when organizations do well, people do well. But there might be 5 to 10% of the time when they do run counter. And if we don't step in those moments, that's when we hurt people or create systems that are designed to hurt people.
Well, I recognize that we're not doing well. I see these very depressing reports from the Commonwealth Fund that come out comparing our overall health outcomes and, mortality rates with other developed countries, and we do not score well. And so there is a participant also who's asking, what are your thoughts on health systems in other countries? Are there countries caring for a diverse population where there's not such disadvantage that cycles through generations? Who's doing this well, if anybody?
That is a great question, one that I don't have enough understanding of other nations' models. While I know they all struggle in different ways, there are no perfect human systems. I find that many of our peer nations have used the state to organize some basic healthcare resources available to all, whether that's Canada, Britain, France, Singapore, many of our peer countries have those basics. They also often have the opportunity to receive more than the basics. And the question often becomes, well, how many folks within those populations are accessing and being prioritized in these additional resources, and are they in competition? There's a basic question that I think has been at issue in the United States, which is, what is the role of the state itself? And I think that what we've seen is the state has been receding. There's a big debate as to whether or not they should fix the subway in New York. There's been a lot of conversation about, how much should the CDC be directing our public health? Whether or not schools should be, more public or less public. I think in other countries, they see very importantly the role of the state to deliver things that are shared in common and required by all, that I think is debated here in ways that I think, like the French would see as foreign and incomprehensible. One of those things is healthcare. They see that as something that, since everybody needs it, there should be some shared, democratically allocated resources. And so while it is socialist in its nature, it protects people. We don't see that, right? We don't, if you look at the Affordable Care Act, there was an opportunity for there to be a public option where they would put, the public resources and the care delivery process in direct competition with the private. It's not something that Americans really wanted. I don't think that there is the same level of trust of public institutions. Some of that is probably merited. I don't think that we have the same recognition that we ought to be a part of these shared institutions, that I think they're a common conversation. There's a American culture that says, look, we're independent in ways that other countries see as collective. And I don't know that those will change. I think that those are embedded in the narratives and histories that we tell ourselves about who we are. Yeah. And in fact, because I think it is embedded there, one of the most effective tools, I think, in progress is going to be art. I mean, I think that the way we shape what can be and imagine what might be is in the stories we tell, is in our art, is in our music, it's in our comic books, it's in our science fiction. It's, what is a hero, right? That's art. What is a good society? That's also art. And so I think that while, I am in a very practical profession, I use my hands and brains to try to take care of sick people. I actually hope that our artists are thinking carefully about how we might imagine ourselves in the future, and telling those stories to help lead us to a new vision of what it means to be a part of a collective.
That's just such an intriguing thought, actually. I love the the integration of these other ways of thinking, and the releasing of the imagination to create something really, truly new. And I totally agree with you that the legacy that the country was built on is one of individual freedoms for some, not all.
For some.
And, yeah. And, that's going to be something it seems to be hardening as people either come down on one side or another of that preference, the collective versus the individual. And so you kind of wonder where that's all going to go. But I think, it's a very difficult question. I think to your point too, trust, there is something I read, it's called the Edelman Trust Barometer. And that tracks, trust across different kinds of institutions. And there's been a clear decline in trust in all kinds of institutions, as you just said, schools, government, state, the way states are run, education, media, especially. Mm-hmm. And that seems to be, really, that's also increasing, and trust is decreasing. Mm-hmm. So this is a significant problem. And to your point about humanity, honestly, I just think we make change. I remember a mentor said this to me, I was sort of feeling overwhelmed, like, what am I supposed to do? And this person said, you can only make change one conversation at a time. And, to your point, and to the questions coming from our participants, what can I do? I heard you say you need to, if you see something, speak up. You don't have to tolerate what you're seeing, seize your courage and say something about it. Be honest.
Yeah.
Gather your crew around you. Gather people around you who can help and who can advocate and to push change forward. Those are some of the things that I think people can do.
And I think it's, to be honest, it's hard to do. I think that oftentimes people feel very alone. I think they feel like they're pushing against an immovable object. And I think that they feel as though speaking up will only get them hurt. But I don't think that they recognize how many people they have in their corner, and that having colleagues and peers who you trust and can rely on not only keep you honest, but also serve as a power base for asking questions, honest questions. Uh-huh. And I think that much of what one can see when there is, an unjust allocation of resources within their environment can be really amenable to pointing it out. Why is it that we don't allow for patients like X or Y to come to this clinic? Uh-huh. Ask the question.
Yeah.
In a public forum, allow for the answer to come forward. I think that the truth is incredibly powerful, mm-hmm. which is why people are afraid of it, afraid of asking it, and find those who speak truths consistently to being, kind of scary and influential. And I think that there's practice that come from wielding that influence. And you've got to start practicing early. I encourage trainees to, challenge us regularly. And I encourage folks, when they start to see these things, to practice it. Start asking the questions. Just start gathering their peers around. Don't wait until it's safe, because it'll never be safe. Don't wait until everything is perfect. Start asking those questions every day.
That's fantastic. It just takes a ton of courage and a lot of friends to help hold you up. So I am afraid we have to wrap up the conversation. It's just been so great to talk to you, Tom. I hope we can continue this conversation. But I do want to thank everybody who's tuned in here today. Thank you for joining us. Thank you, Dr. Fisher.
Thanks for having me.
Yeah, we're going to take a quick 15-minute break, and then participants can sign back in or join their breakout sessions. all you have to do is refer to your attendee hub to select your next session. So thank you all very, very much. And thank you once again, Dr. Fisher.
That was fun. Thank you.
Yeah, enjoyed it.